Welcome to ATCM, the Emergency Medicine Channel. 42-year-old male, status was ABG 4 days back on ecospirin and Brilinda, came to ER with complaints of bleeding from left nostrils 10 minutes back. Initial 10 seconds assessment, airway was patent with no pooling of secretion, gargling sound stridor, able to complete full sentences, breathing, respiratory rate of 20 per minute, saturation of 97% in room air, on auscultation bilateral air entry present with no added sounds. Circulation, heart rate is 100 per minute with a BP of 150/70, all peripheral pulse palpable. Disability, GCS of 15 by 15 with pupils equal and reactive to light. Exposure, temperature is normal with a GRBS of 140 mg per dl. History, presenting history, sample history, 42-year-old male, status was ABG, 4 days back, type 2 diabetes, hypertension, on ecospirin and Brilinda, came to ER with complaints of bleeding from the left nostrils 10 minutes back. History of nose pricking was there prior to the episode. No history of fever, rhinitis, air travel, foreign body, facial trauma. No history of any nasal discharge or headache. At the presentation of time, patient had a few, not profuse bleeding, but few drops of blood were coming through to the left nostrils. So we kept the patient in a sniffing position with pinching of ALA for more than 10 minutes, and following which bleeding stopped. We also given ENT consultation on.
Okay, so whenever a patient comes to ER with epistaxis, in the primary survey, what all things will you give importance?
In primary survey, we should check for airway patency and any severe sensibility, like the patient is in hemodynamically stable, like heart rate, BP, and everything we have to check. And also, if it is not hemodynamically stable, we have to fluid resuscitate the patient by applying 2 large bore cannula.
Okay, so first importance to airway, any patency. If at all the patient is having low GCS or anything, or if at all there is profuse bleeding, or if it is a trauma case and all, that is causing multiple fractures and all. So in that case, airway is a priority there. So airway we need to check. Then is the circulation. Circulation we need to look for any hemodynamic instability, as you told, any hypotension or any tachycardia that needs to be looked. And then is disability. That is, if at all there is active bleeding, we need to control that. That can come in circulation also. Ongoing bleed also should be managed. Okay, so when you are taking the sample history, what else will you ask?
Whether the medicines are taken, like any history, the timing, recurrence is there, or how many minutes it was there, how profuse was the bleeding, the quantity and quality of bleeding, any predisposing factors, whether like nose pricking, any coagulative disorder have patient, then like any prior history of the patient you have to ask.
Okay, any trauma history. And this patient particularly, what medicines this patient?
Ecospirin and Brilinda.
Brilinda. So patient is on 2 antiplatelets. Okay.
Antiplatelets.
Okay, so that should be done. So any specific investigations do you need to do for this patient?
We have to look, if we are suspecting any coagulation disorder, we have to look for PTINR and APTT, and if it is profuse bleeding, we have to know HP of the patient and hematocrit. So any bleeding, HB drop is there or not, we have to.
Okay, so that HB drop you need to check, any coagulopathy you need to check, any thrombocytopenia you need to check, and also if at all it is a new patient without any prior visit to us, in that case we need to look for any liver failure or renal failure, because liver failure can cause coagulopathy, renal failure can also cause uremic thrombocythemias and all, causing this thing. Okay.
Then after that we given
so suppose we have a patient with active epistaxis, how will you manage in ER initially?
First initial 10 second, like airway patency, breathing, circulation, disability we have to check. Then first we have to give local pressure to the nostrils we have to keep the patient in a sniffing position with waist bending forward and asking to pinch the nostrils together for minimum of 10 to 15 minutes. We can also give oxymethicillin nasal
Okay,
spray.
so what is the importance of doing like that?
We are giving local pressure, so we are local pressure like vasoconstriction. We are blood vessels. We are giving pressure so that coagulation or bleeding can be stopped.
So where all can the bleeding happen in an epistaxis?
Epistaxis, basically it's divided into, it could be an anterior bleed or a posterior bleed. Anterior bleed, the most common site is Little's area or Kesselbach's plexus, and the supplied by 3 branches from septal branch of anterior ethmoid, then lateral nasal branch of splenopalatine, and also septal branch of superior labiofacial artery. And in the posterior, it's mainly from branches of splenopalatine artery.
Okay, so mainly from blood supply to the nose comes from the internal and the external carotid artery. So from the internal carotid artery only, internal carotid artery branches into anterior and posterior ethmoid. In that, anterior is supplying the anterior part and posterior is behind. Then from the external carotid artery, from the facial branch, the labial will come, and also we will get the superior and sphenopalatine, greater and sphenopalatine. So mostly 90% of the bleeding happens
Due to trauma.
That too in the anterior, the Kesselbach's plexus, the Little's area, mostly because of any nose pricking or something. And posterior happens because
Mostly due to bleeding disorders or anticoagulation
or hypertensive bleed in case of elderly. Okay.
Then
so when you are doing a compression, what we are trying to create is that we are trying to give an external pressure so that the tampon effect will be there, and we will be, how will you ask the patient to breathe
through the mouth.
And whatever blood is coming, patient need to spit it in front. Okay. So if that is not working, after 15 minutes, what will you do?
We can give nasal nasal vasoconstrictors like oxymethicillin or a Tranexa also we can try.
Okay, so a Tranexa we can try, that is correct. Tranexa we can give as either as an injection or we can give a Tranexa nebulization, but in that should be given if it is not a very severe bleeding. If it is severe bleeding, what else can you do?
Yes, nasal packing.
Before going to nasal packing, first step is always Trotter's position compression. Second is nasal cautery can be done. How will you do nasal cautery?
With chemical cautery or electrical cautery. Chemical cautery, silver nitrate can be used.
Okay. Electrical cautery, if you are planning to do, you need to give local anesthetic like novocaine or silocaine with adrenaline should be given. Chemical cautery, how will you give with silver nitrate?
Silver nitrate spray, only one side we have to give. Bilateral should be avoided to prevent septal perforation.
Okay. So if at all you are planning to give, do that, how will you give? Either you can give us a spray, or what can be done is that you can take it in a this earbud like a pig. You can take and dip silver nitrate and you need to apply over that area. How much time will you keep the silver nitrate in that bleeding spot? First, we need to identify the bleeding spot. If at all the patient is having active epistaxis, do a flexible suction over that area. Find out the bleeding spot, dip the silver nitrate into the cotton swab and keep it within less than 30 seconds. And that area will turn into a grey pale color. Then you can take it out. You shouldn't keep it more than 30 seconds because that can cause this perforation risk and necrosis can happen. So like that you can do, or you can do a chemical electrical cautery that we usually don't do in ER. If at all we are planning to do, how will you cauterize that area? Electrical cautery, you can do it as a horseshoe shape, not all around this thing. You will have to do like a horseshoe shape. We'll have to do a cauterization, and if that fails only, we will be planning to do a packing. How will you pack?
Either andronasally, then we have to repeatedly.
So we want, for that we need a anterior nasal speculum. We need a anterior nasal speculum to open the nose. Then with the Tilly's forceps, we will have to insert. That is a long forceps, like a long teeth like forceps. With the Tilly's forceps, we need to introduce the gauze roll. So how much length that gauze roll will be?
The first layer is 1/4 inch petroleum, 2 to 3 centimeter from the end we have to introduce. Then come back and we have to repeatedly from up to like lower region to above we have to give layer.
Okay, so for that, what gauze will you take? You will have to take a long gauze, at least 1 meter length should be taken, and that should be impregnated with
petroleum. 1/4 inch of petroleum.
You can use as a Vaseline, like a liquid petroleum, or you can use liquid paraffin or bismuth iodinated paraffin powder, paraffin paste can be used. That should be used, and you need to introduce it. First, when you are layering, we will be inserting from here to here. First, you will have to layer it horizontally like this. So inside the nose, it will be like horizontally. Then last layers should be vertically. So first you will have to insert it like this, then after that it will be almost full in that area, then we will have to insert like this, so it will be vertically. So initially it will be going like this, then it will be coming like this. Okay, and how much time can you keep that packing?
24 to 48 hours.
Okay. If you are keeping more duration, should we
add antibiotics? We have to add. If more than 48 hours we are planning to keep a nasal pack, we should add antibiotic like any augmentin or like basic augmentin to prevent toxic shock syndrome or something.
To prevent bleeding also. Okay. So what other things can be used for packing, nasal packing?
That Foley's like tamponites we can use. Then Foley's catheter we can use. 14 gauge Foley catheter we can use for posterior.
Anterior and posterior. Mostly posterior we will be using a Foley's catheter and we will inflating it. Then anything else?
Anterior Epistaxis balloons we available, which are like rapid rhino balloons, which can be easily inserted and inflated with the air.
So how will you introduce this rapid rhinos? How will you introduce an nasopharyngeal airway? What is the lubricant used?
Normal saline.
Saline. So saline is a normally used lubricant. So if you are using a gel-based lubricant, if you are removing, that time it will cause erosions and all. So better use a lubricant with the saline. So rapid rhino is actually a small balloon-like thing. So you need to dip it in sterile water or normal saline and introduce to the patient, and it will be having a tip inflate with air, just like you do for Foley's catheter, but we are inflating with air. Or what else can be used?
Or performed nasal tampons or sponges are there. Here we apply it and we'll give some water so that it will get inflated.
So what is the thing which we use here?
Here we use balloons.
Here we use Merosil. Have you heard about Merosil?
Yes.
Merosil is actually one flat thing. Like a flat thing means just like a have you seen ice cream stick? In that, like that, a flat thing. So you will have to, that will be little bit hard. You will have to put few drops of saline in that so that it will start becoming soft. Introduce it to the patient's nose. Then we will have to push some more saline inside so that it will expand inside the nose. That is how we use a Merosil. Okay. And if at all the patient is having posterior bleeding, what will be the manifestation? Will the patient come with epistaxis or something else?
Melena or hematemesis.
Not melena hematemesis. Patient might have oral bleeding, or if the patient swallows, melena or hematemesis. So how can you control posterior nasal bleed?
Like posterior tamponade. Posterior.
How will you identify it as posterior nasal bleed?
Like, first thing is when there is brisk bleeding with the source can't be identified on the anterior aspect, or the bleeding is still profuse even after bilateral nasal packing, we have to suspect posterior bleed.
Okay, and we can do a posterior rhinoscopy or a nasal endoscopy to confirm. Okay.
So in case of posterior bleed, we can try posterior nasal packing. We can try, or a Foley's catheter we can use. A 14 gauge Foley's catheter, we have to remove the tip and we will introduce to 1 to 2 centimeter posterior to the posterior pharynx, we will insert a 7 mm, then we will retract it and then insert again.
Okay,
It give a tamponade effect.
Okay, if at all we are not having any Foley's, what else can be done?
Packing, like
Foley's can be used, or proper posterior nasal packing is by using, you can use a, we have a swab here, right? Normal swab is, you can roll it into a thumb shaped thing. So it will be looking like a roll. Then you will have to tie 3 threads to it. 2 at the periphery, 1 at the center. Okay. And you need to introduce 2 catheters, like a soft catheter, like a Foley's or any type of catheter can be. 2 catheters should be put from the nose, so that it will come through the oral cavity. 2 catheters through the nose that will come through the oral cavity. Okay, so first 2 catheters came out. Then we have this thing. That thing is the gauze with 3 strings. So out of that 3 strings, 2 strings from the 2 ends should be tied to this catheter, and this catheter will be removed back like this. Understood? So that the string attached to the catheter, so we need to, this thing is already coming from the oral cavity. That is connected to these 2 strings. So when you pull it from the nose, what will happen? That roll will go and sit in the posterior cavity. So that's 2 strings which we have connected to this will come like this, and the 3rd string which was in the center will come through the mouth. Okay. So that thing will be in the posterior cavity.
Posterior packing is associated with higher complication rates like pressure necrosis, infection, hypoxia, and cardiac dysrhythmia, especially in patients with undergoing cardiopulmonary disease. Then treatment, there is an algorithm for management of epistaxis in adults. If there is,
so we have told about some blood investigation. Any radiologic imaging we can do for epistaxis? If at all we don't know the cause why it is bleeding,
angio we can do.
Basically, what thing we will do basically in the ER? First we'll start with X-ray. X-ray, what all things can you see?
Any sinusitis or any trauma
or fractures you can see. CT also is more specific, that we can see any trauma, fractures or anything can be seen. Then we can also plan on doing an angio. Angio, we can see the bleeding and we can embolize also. That is the advantage of angio. Okay.
In active bleeding, first we have to look for airway. If it is secured, or breathing is normal, or circulation is normal. If everything is not, if airway is not secured or breathing is not normal, we have to resuscitate as soon as possible, and also have to immediately contact an ENT and also intervention radiologist to do to cauterized or radiological management. So if it is everything is normal, like airway is secure, breathing is normal, circulation is normal, we will first try conservative management, which include patient to bend forward and squeezing the ala together, and also can give oxymethicillin 2 sprays, which will cause a vasoconstriction. So if bleeding is stopped with conservative method, we will observe the patient for for nearly 1 hour for any rebleeding. If there is no rebleeding, we will discharge the patient and ask to review after 48 hours in ENT OPD. If bleeding is still persist, we will perform an rhinoscopy to identify the source, whether it is an anterior or posterior. If anterior source is identified, we will first start with chemical or electrical cautery of unilateral bleeding spot. If cautery is unsuccessful, we will insert an anterior packing. The options include nasal tamponade plus or minus tranexamic acid, or anterior balloon or gauze we can use. Still bleeding is persisting, we will do bilateral anterior nasal packing. If with packing it is bleeding reduced, we can discharge the patient, asked to follow up after 48 hours. If still even after bilateral nasal packing bleeding is still persist, we have to rule out posterior source, and if anterior source cannot be identified, we have to suspect posterior source of bleeding. If posterior source is suppose is likely to be the cause of bleeding, we will apply posterior nasal pack, which include posterior plus anterior ballooning or Foley's catheter, and we will urgently consult. We give an ENT consult. If with bilateral nasal packing bleeding is stopped, we will discharge the patient and review, or in case of high risk like infection or respiratory difficulty, we will admit the patient in case of persistent bleeding.
So what happened to this patient?
This patient, since after conservative management patient's bleeding stop, we give an ENT consultation and discharge the patient with Augmentin, has to review after 48 hours.
Okay, so we just had to do the nasal compression, and we are suspecting the cause of bleeding mostly because of the antiplatelets. Okay, and nose pricking.
Nose pricking.
Okay, anything else?